All right, guys, we're going to go over the studies for this week. I have 3 different studies up here. I have the normal chest CT, traumatic aortic injury, and contained traumatic aortic injury. These 3 links are in your course in the Research Helpful Links tab under Module 5. So you guys can scroll through and look through these on your own time as well. So starting with, I'm in the normal chest CT, and you can see the different reformats we have here. We have the axial in a soft tissue, an axial in a lung window, and then we have 2 coronal reformats in a lung and a soft tissue. So we'll be looking at those in a second. First, we're going to start with the axial soft tissue. We'll start all the way at the top. All right, so the most superior slice. Let me center this better for you. All right, so we're at the most superior slice. The first thing you want to do is start pointing out the bony thorax and the borders of the bony thorax. So the bony thorax is bordered posteriorly by the T-spine. So as I scroll down and you see this is C7 right here, as you see the first rib coming off, this is T1, okay? So T1, the T-spine, T1 through T12 are the posterior, they make up the posterior border of the thoracic cave or the bony thorax. The lateral borders are the ribs. So you can see as we go back up and come down, the ribs are going to circle around and make up the lateral border of the bony thorax, okay? And then now anteriorly is going to be the sternum, which contains 3 parts as I go back up. Manubrium is your first part, the sternal body, and as we go down, and then this little pointy guy at the end, at the most inferior portion, is the xiphoid process. Okay, so that is the borders of your bony thorax. Starts superiorly at T1 and then goes all the way down to the diaphragm. Okay, so diaphragm right here. You can see diaphragm. Okay, and it's the domed diaphragm that's going to cover over the top of the liver and the abdominal cavity on the left side as well. Okay, so bony thorax, thoracic cavity. The other thing I want to point out, which you can see in an axial slice as well, although they show up much better on a coronal, are the costal cartilage attachments. Okay, so you can kind of see them as we go up to the top, and we have the first rib coming off right here, circling around and attaching here. There's just a little bit of cartilage here, but as we go down and we see the rib attachments, you can see the costal cartilage here getting wider and wider, okay, as that rib cage kind of opens up. And then remember, as you get down to ribs 8 through 10, you have, they piggyback onto the costal cartilage. So let's pull up the coronal soft tissue, and I'll go anterior, and you can see here's the costal cartilage here coming in, piggybacking, okay, onto each other to attach to the sternum, okay? So, and here's your xiphoid process down here. The inferior, most inferior portion of the body of the sternum right here, and then these are your piggybacked costal cartilage attachments for ribs 8 through 10. And remember, 11 and 12 are floating ribs. They don't have anterior chest wall attachments. All right, so those are your anterior chest attachments of your bony thorax. Let's go back to our axial. Let's scroll all the way to the top again. So we have our bony thorax. We have the other thing that I want to point out is, which you can see right here is actually a good slice, the posterior attachments of the ribs. So we talked about the anterior attachment at the costal cartilage. Posteriorly, we have 2 joint spaces, costovertebral joint space, where the rib attaches to the vertebral body, and the costotransverse joint space, where the rib attaches, or the joints rather, of the rib and the vertebral transverse process of the T-spine. Okay, so that's the other joint space. And you can see all of them as you go down. That's a nice view right there of those joint spaces, right? All right, so costovertebral, costotransverse joint spaces. Going back up, you should be able to see clavicle. So here's your clavicle coming over. Okay, so there's your AC joint. There's your acromion, your clavicle. Follow it anteriorly. There's your SC joint, your sternoclavicular joint right here. Okay, so you should be able to see clavicle as well. We won't concentrate so much on the scapula because we're going to go over that when we do upper extremity anatomy. You should be able to count the thoracic vertebrae. When you start with the ribs, your first rib is going to be T1, so T1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and then I should be in L1 right there. No rib attachment. Okay, so easy way to count your ribs in the axial slice. Now let's talk about the thoracic openings, the inlet and outlet. Remember, they're like a cone with a narrow opening at the top and a widened opening at the bottom. This is basically just openings that allow a conduit or a tunnel, if you will, for anatomy in the thoracic cavity to connect to anatomy superiorly in the neck and then ultimately up into the head, or inferiorly down here, down into the abdominal cavity. So if we need to have any connections between the two, the inlet and outlet would be the means to connect those two cavities, the thoracic and abdominal or thoracic cavity, and then up into the neck. So starting superiorly, the thoracic inlet, it is formed by T1, the first ribs, costal cartilage, and manubrium. So T1 is right here, thoracic, first thoracic vertebrae. The first rib as it comes around, and we're kind of superior, and I'm going to scroll down so you can imagine that this circle is kind of tilted anteriorly, on the anterior side, it's tilted inferiorly. So it's kind of like an oblong opening. So here's your posterior aspect of the first rib coming around, attaching at the manubrium. Okay, so there's your thoracic inlet. The smaller superior opening allows for the passage of nerves, vessels, and certain viscera like the trachea, the esophagus, which you can see collapsed right here, posterior to the trachea, in and out of the thoracic cavity. Inferiorly formed by T12, the 12th ribs and costal margins, and the xyphosternal junction. So let's go all the way down to T12, which is right here. There's T12, so here's the posterior border of the thoracic outlet, and then we could follow these ribs. This is now tilted the other way, where the anterior portion of the thoracic outlet is pointing superiorly. Okay, so we have a circle that's now pointing with the anterior portion superiorly, oblong in the opposite direction. So as I go up to the xyphosternal junction, which is right here, okay, that is going to be your anterior border of your thoracic outlet. Okay, so inlet, outlet, sternum, manubrium, the ribs, counting the vertebrae, costal cartilage, costovertebral, and costotransverse joint spaces. You should all be able to identify on the axial. We can switch over to the coronal to kind of see the same things. It's going to be different seeing, it's not going to be as easy to see your joint spaces posteriorly because we're looking at them not in a cross section like we were before, but you can still see the costovertebral joint space here and costotransverse joint space here. So you can kind of see them. We can see obviously our lateral borders really well in the coronal slice. Posterior, when we go all the way back, there's your posterior border, your T-spine and the posterior ribs of your bony thorax. And then anteriorly, obviously quite easy with our xiphoid process here, xyphosternal junction here, our costal cartilage, and then our sternal body, all the way up to the manubrium right here. Let's see. Let's go over and start talking about the lungs. So we're in a really good coronal here to talk about the lungs. So the first thing we can do, talk about right lung and left lung. Okay, in a soft tissue window, we're not going to be able to see everything we need to see with the lungs. We would have to switch over to our lung window, but we'll start here with the soft tissue, right and left lung. First thing I want to point out is the indentation in the lung that allows for passage of vessels to go in and out. Okay, these indentations, that's the hilum of the lungs. So here's right hilum, here's left hilum. The other thing I want to point out with the left lung, you see this notch right here, allows for the heart to nestle right in there, snug in that notch of the lung. That's your cardiac notch of the lung. And then just inferior to the cardiac notch, this little thing that looks like a tongue actually, is the lingula of the left lung. Okay, very easy to see on a coronal slice when there isn't traumatic injury. When we switch over to the traumatic ones, you're going to see how there's going to be fluid in here, and we're going to have shifts because of the fluid and pneumos and that kind of stuff. It's not quite going to look the same. But in a coronal, it should be pretty easy to see the lingula, and I'll show you how we can point that out in an axial as well. Okay, we have the aortic arch right here. Okay, you guys should be able to recognize it in a coronal because you are pointing it out on chest x-rays. There's your descending aorta. We have, what else? The trachea coming down. The area where the trachea first bifurcates or splits is called the carina. And the carina is a really important piece of anatomy to be able to visualize as a CAT scan tech, especially when you're doing pulmonary embolism studies. So you're doing a CTA of the thorax for PE, because the pulmonary arteries right here are really easily seen right at the level of the carina. They're actually just below. So when you are setting up a study for a CTA of the thorax for PE, you want to look at the carina because it's very easy to see the carina on your scout image, and then you can set up your scan to be in this area so that when you're doing the scan, this vessel, the right pulmonary artery and the left pulmonary artery, are filled with contrast. They're bright white, and we can look for any filling defects and see if there's a pulmonary embolism. So carina. The other important thing I want to point out here first is the trachea, the airway coming down, bifurcates. I want you to notice how wide the right main stem bronchi is compared to the left, okay, and how vertical the right is compared to the left. So you guys know and should have learned already at this point that aspiration pneumonia is typically going to be found in the right lung because food comes down and it has a much easier path straight down into the right main stem than making this little bit of a turn over to the left. So right is going to be the lung most typically suffering from aspiration pneumonia and or foreign body invasion. So any foreign body that may enter into the lungs via the airway typically is going to end up in the right side. And that's why. So I want you to see that. Here's your right main stem. Your left main stem is a little bit longer before it eventually branches into its secondary and then branches again into lobar. The right branches pretty quickly and shoots off, but then this one branch of the secondary is still straight down. It's still pretty vertical. So still allowing for easy foreign body invasion. So there's your trachea going down. In a soft tissue window, it's not really easy to see a lot of lung anatomy, and it's especially not easy to see the pleural linings, which we'll talk about in a second. We'll definitely be able to see pleural linings if there is something that's occupying the space between the pleural lining, the parietal pleura, which is the lining that lines right along the outside of the thoracic cavity. And then the visceral pleura lines right along the lungs, or the viscera, in the thoracic cavity. So if there's nothing occupying the space between the pleural space, between the parietal pleura and the visceral pleura, you're not going to see it. Remember, it just has that serous fluid that just allows for easy movement of those two spaces, not spaces, those two pleura along each other. So as the lungs are inflating and deflating, the visceral pleura is able to easily slide along the parietal pleura. But with any pleural effusion, where there would be fluid in that space, or with a pneumothorax, where there might be air occupying that space, we will definitely be able to see. And when we switch over to the traumatic injuries, you will definitely be able to see the two different pleural layers. So let's switch over to our axial and look at the same thing. So trachea coming down, coming down, coming down, coming down, and then there's your carina, okay? There's the first bifurcation. I want you to look at, remember we looked at the right main stem bronchi, and it almost immediately branches off laterally, and then the left doesn't branch quite yet, but it does make a left-hand turn and moves over and travels a little bit more horizontally. So how that's going to look on a CAT scan is our right main stem bronchi is more vertical, so we should see more of a complete circle of our right main stem, and our left is going to start to become oblong because it's traveling in the left direction. So as I scroll down, you're going to see oblong. This is still our first branch of our right, but our right, you can see, is a nice circle, which means it's still traveling inferiorly. It's vertical, whereas our left is oblong as it's traveling horizontally, okay? So right main stem, still straight up and down. Left has now taken a shift over horizontally, so less chance of aspiration or foreign body invasion. The other thing I want to point out, remember I told you that locating the carina on a scout view is going to help you to visualize or see at about the level of where the pulmonary arteries are. So if I were to travel up, this is the aortic arch coming in here. So ascending aorta is then going to candy cane over and become descending aorta. So there you go. There's your arch going down like your candy cane. Our carina right here. So I'm just starting to bifurcate my trachea into my right and left main stem bronchi. And then now I want you to see these vessels coming in here. This is your main pulmonary branch, which is going to bifurcate to the right pulmonary artery and left pulmonary artery as I scroll down. So there's your right and there's your left, okay? So when we're looking for a pulmonary embolism, we're going to be looking in these vessels here, okay? It's coming up from the heart and from the main branch, and then it branches off to right and left pulmonary arteries. So there they are. Okay, so locating the carina is going to help you to place an ROI, which is the circle that you put in here that's going to detect the Hounsfield units. Remember, the Hounsfield units is the density of a CT number assigned to the density of the tissue in that area. So when we put a circle there and it measures the Hounsfield units, when it is at a certain threshold, that's how we know that the contrast has properly opacified this vessel to be able to initiate the scan, so we can visualize this vessel full of contrast, so we can look for any filling defects to see if there's an embolism. So looking for the carina is going to help you to determine the proper level for that. So going back to the lung, talking about the lung, we have left lung, we have right lung. We're going to go down and look for the indentation that allows for the vessels and the airway to travel into each of the lungs. And when we hit that indentation where that stuff starts to happen, that is going to be your hilum. Okay, so right here is your right hilum, and over here is your left hilum. All right, and as I travel inferiorly, I'm going to see a notch notched out in the left lung that allows for the heart to sit right in there. There's your cardiac notch. And then remember that little tongue piece anteriorly that looks like a tongue? The lingula of the left lung sits just anterior to the inferior portion of the heart, right there. Okay, so hilum, lingula, cardiac notch on both a coronal and an axial view. You should be able to see. Okay. Hilum of the right and left lung as well. Let's go back over to the coronal lung window. Here again, your cardiac notch and your lingula. I want to talk about these right here. The horizontal fissure of the right lung, the oblique fissure of the right lung. And we're not quite seeing the fissure in the left lung. It's kind of right here. It's this little like kind of, we're not getting it in a good slice where we're seeing here a nice distinct line. We're kind of getting more of a blurred lining, so you can kind of follow it up. And you can kind of see this line here. That's your left oblique fissure of your left lung. So there's one fissure in the left lung that divides the left lung into superior and inferior lobes, or upper and lower. And then there is the horizontal fissure of the right lung and the oblique fissure of the right lung that separates the right lung into its three lobes, the superior, middle, and lower lobes, or upper, middle, and inferior lobes. Okay? You're not going to be able to see these fissures on a soft tissue window. You need to have the lung window showing all of the lung markings in order to adequately visualize those fissures. And even then, sometimes, as you can see here, it's difficult to see them. The other thing I want to point out as I go anterior, I want to look at the trachea. So the other thing I want to point out in the lung window is how easily you can see the trachea coming down, the main stem bronchi, and then watch how they start to divide and travel out to the lower recesses of the lung. So you can see how we're following here. This is kind of branched off, there's a branch, still going, there's a branch. It's going to get harder and harder the smaller you get, obviously. Here's a branch right here. But these circular branches that have the dark spot in the center are your branches of your bronchi. So remember, your bronchi are main stem, secondary, or lobar, tertiary, all the way down to the alveolar level where we have gas exchange taking place. So you're going to be able to see them easily on a coronal, but when I switch over to the lung axial, I want you to see how low you can follow them. And they are going to go down pretty low. You can follow here all the way down to about there. So you're seeing part of a branch there, part of a branch there. These other branches that you're seeing coming out, these are vessels, okay? They're white because they're filled with blood, all right? So those are heading out to the far reaches of the the lung tissue itself. So remember, we have to have blood vessels that go down there too, because we have gas exchange that happens at the alveolar level, but it circulates to the circulatory system so that we get proper gas exchange. So here's your here's a airway, one of your secondary or tertiary. This is probably even down into your lower segmental branches, bronchioles, alveoli down in here. But they're going to follow along with the vessels. You're going to see them following along with a vessel, whether it be an artery or a vein. So those are your different branches of your bronchi that are going to segment down into all of the different lobes and then segments of the lung. Again, you don't have to know specifically which is this, a tertiary or a secondary. That I'm not going to require you to know. You do have to know trachea, bifurcation, right main stem, left main stem bronchi, and then this would be your first or secondary branch coming off of the right. This would be your first secondary coming off of the left. That you would have to know. Those are pretty basic branches to know. Okay, so those are the lungs there. Let's switch over to one of the traumatic lung injuries so we can see the difference between the anatomy. So we'll go back superiorly. First thing I want you to notice, trachea. What's that in the trachea? This is a traumatic injury. This is an ET tube in the trachea. So this patient is intubated. We have our T-spine here, first rib coming off. So we can still, even with a traumatic injury, we can see the first rib and we can identify the thoracic inlet. Okay, we have rib fractures over here, which you can see coming in, which is part of the reason why this patient has, there's a fracture right there. All of this is air, subcutaneous air, because some of the air in the lung is coming over here because we have this patient has a pneumo, I believe. There's fluid in the pleural cavity. So here, what we're seeing is this posterior lining, and you can kind of see a smidgen of it here, right? This is your parietal pleura, and then everything that is lined in the lung in here is your visceral pleura, okay? And then in between the two, we have fluid, okay? So that's why we're able to see the two different, the space between the two different pleura. Over here, we have the visceral right along here, and parietal posteriorly, you can see, and then there's fluid in between the two linings, okay? So when you have traumatic injury or you have some kind of pathology that is occupying the space between the visceral and parietal, you have an ability to see that pleural space. So going back up, other things you should be able to see, the trachea, the bifurcation, there's carina, and on this patient, this is kind of an arterial study. You're seeing the main pulmonary branch, right pulmonary artery, left pulmonary artery, right there. So if they were looking for a PE, they probably could rule one out with this study. But you can see how the artery is kind of white. Ascending aorta, descending aorta. Let's go back up and look at manubrium. Sorry, up. Manubrium right here. First segment, sternum coming down, body of the sternum, and then our little tiny poker down here is your xiphoid, okay? And then here's our costovertebral junction and attachments down here. And this patient is older. They have some calcification in here, which is normal. You guys should have all seen that on a chest x-ray as well. It's just much more detailed on a CT. So there's that on a traumatic injury. Let's switch over to the bone anteriorly, and I want to show you those costal cartilages, and you can actually see them piggybacking really well in here, and you can see the calcification really well as well. I always like this image on a CAT scan. You can see all of the little ridges in the sternum, which are there as attachments for each individual costal cartilage, okay? So you can see exactly why we have these little indents and ridges in the sternum and to attach the costal cartilage. And here's piggyback down here. Piggyback right there, okay? So there's your cartilage attachments. Let's switch. Oh, this gave us one slice of an axial in the bone. Let's switch back over to our axial. And even in a traumatic injury patient, I want you to point out the cardiac notch, the lingula. Here it almost looks like a duckbill. Okay, the lingula, cardiac notch, and then going up where the vessels and the guts or the good stuff going in and out, the indentation, the hilum of the right lung and the hilum of the left lung. Okay. Let's go to the other traumatic injury so we can see the difference there. Oh, here we're seeing a really good, here's the visceral pleura, posteriorly the parietal pleura, and here's some air, or not air, fluid in here. Okay, so we're seeing that space. Same thing over here. Parietal, visceral, and then in between, fluid. Okay. Cartilage coming up here, piggybacking up to the sternum. Cardiac notch. Lingula is a little displaced in this guy. All right, last thing we should look at is the mediastinal, or are the mediastinal compartments. So to see the mediastinal compartments, the easiest way to visualize them is in a sagittal reformat. So in the sagittal view, and remember, the mediastinum is just this central portion, okay? It's just this portion right here. It's what is traveling up and down and then over to in the central portion, the very central portion of the thoracic cavity. It's not over here, it's not over here, it's just the central portion. So that's why we really can only look at it. I mean, radiologists and stuff, I'm not going to make you guys know that. They look at it from a coronal, but for you guys, it's going to be much easier to look at it from a sagittal slice. So the two main compartments, okay, the superior mediastinal compartment and the inferior mediastinal compartment. The superior goes from T1 to T4, okay, so we want to look for T1 and T4. I believe this is T4 right here. Let's just double check. Let's go down here. It's going to be easier to look for ribs inferiorly, I think. So here's a rib coming off. There. This is T12. Yes? Let me look. 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Yes. All right. So here's one right here. The superior mediastinal compartment goes from T1. Draw an imaginary line from the anterior of the body of T1 over to the superior portion of the manubrium, and then draw another imaginary line from the inferior portion of the manubrium over to the anterior body of T4. 1, 2, 3, 4, right here, over. Okay, so this area is your superior mediastinal compartment. Okay, everything below that, down to the inferior border of the sternum, is the inferior compartment. And then remember, the inferior is broken up into 3 different compartments: anterior, middle, and posterior. Okay, anterior goes from the sternum, the posterior border of the sternum, to the pericardial sac, which this is the heart right here, so right along here. So this very teeny area in here. The middle compartment goes from the anterior border of the pericardial sac to the posterior border of the pericardial sac, which is right here. Basically, it contains the heart, and then the pulmonary vessels that travel out laterally, so one going towards you and one going away from you, as we scroll back and forth on this sagittal slice. And then the posterior compartment goes from the posterior pericardial sac, which you can see here, to the anterior of the thoracic spine. Basically, it contains the descending aorta. Okay, so those are your mediastinal compartments that you would have to know. They on a sagittal, I would have you point them out on a sagittal only. I'm not going to make you look at them in an axial or a coronal, other than to know that on a coronal, the lateral borders of the mediastinum are the pleural cavities. Okay, so here's your pleural cavity over there and your pleural cavity over here. So your mediastinum is literally the stuff from cavity to cavity in the central portion. Okay, so that's what you should know for this week. I don't think I've missed anything. No. So you guys should be scrolling through just like I did, visualizing the anatomy, being able to point it out, because anything I've gone over here is fair game on the test.